everything you need to know about DLBCL. Watch till the end to find out about new DLBCL treatments. What is DLBCL?
DLBCL basically stands for diffuse large B-cell lymphoma. It is a type of non-Hodgkins lymphoma. So lymphoma is one of the types of blood cancer among leukemias, myeloma, and lymphoma. Those are the three big types of blood cancers. It usually affects people over the age of 60, and it is a very highly treatable and potentially curable disease.
DLBCL is the most common lymphoid cancer in adults, and that basically means a cancer of the immune system. It is seen in about 30,000 patients each year in the United States, and the good news about the disease is that the intent of treatment is to go for cure. The bad news is the treatment is chemotherapy, and it works in about 2/3 of patients.
It's a cancer of lymphocytes. Lymphocytes are a type of white blood cells. They circulate in our blood and they can go potentially anywhere in our body. Their main role in our body is to fight off infections, and over time, these lymphocytes might acquire some mutations, and then these mutations can cause continuous proliferation. These cells might stop dying, and they start forming tumors in our body. These tumors usually start in our lymph nodes. That's why it's called lymphoma, cancer of the lymph nodes, but technically lymphomas can be seen anywhere in the body.
What are the signs and symptoms of DLBCL?
So again, it's a plethora of symptoms, but usually it's patients present with enlarged lymph nodes, either in the neck, armpit, or in the groin, or they may have, if they have lymph nodes in the belly, they may get, abdominal pain. Sometimes they may get what we call as B symptoms or bad symptoms. These include like fevers, weight loss, night sweats. So those may be also some of the presenting complaints. And diffuse large B-cell lymphoma is again not one disease. This is a spectrum of multiple different diseases grouped under one big category. And depending on what part of the body is affected, you can have other different symptoms. For example, if the brain is affected, people could have those kind of symptoms. If the lung is affected or the kidney is affected, you can have those kind of symptoms.
Often these are symptoms that are kind of vague at initial presentation and prompt a doctor to start a workup. Sometimes people could be thought they have an infection or they have the flu or they just don't feel well, but imaging usually is required to see that there are enlarged lymph nodes. And once that's found, then a biopsy is required to determine what those enlarged lymph nodes are. Soon after the biopsy is done, the results come back and usually treatment started within a week or two.
Is there a cure for DLBCL?
DLBCL is in fact one of the most curable malignancies. About 60 to 70% of the patients diagnosed with DLBCL, considering all stages, can be cured from DLBCL.
How long does someone live with DLBCL?
So the treatment usually entails a short course of treatment for anywhere from 5 to 6 months or lesser. And that's what we are trying to improve our treatment approaches. But after that, then you are potentially cured of your disease, and then they become survivors, and we don't consider them any longer as patients.
Some of the patients, and this is a small percentage, 3 to 5% at most, can have heart failure later in life. Infections could be an issue while they're going through treatment or right after the treatment is completed, because these patients' immune system is going to compromise a hit during treatment and right after the treatment as well for a while. So infections are one of the biggest complications. Rarely, patients might run into issues like bleeding or very rarely kidney or renal problems. Not every patient with DLBCL are going to have the same outcome, and this depends on presence of certain poor or good prognostic features.
How quickly does DLBCL progress?
DLBCL is an aggressive cancer, and so it often will grow very rapidly, and that means usually in days or in weeks, patients will become symptomatic and will need therapy relatively soon. This is not a disease where watch and wait or observation would be considered. If the patient has disease with an aggressive lymphoma, they need to have treatment started in the very near future.
The other point also is like this is more of some people don't understand the importance of seeking care early. So if this is diagnosed, it's a disease, again, we don't want to wait 6 months or a year to do some treatment. The tempo of the disease is slightly faster compared to a slow growing lymphoma. So if diagnosed, we would want to start treatment early, because earlier treatment has shown to also improve outcomes.
Where is DLBCL located in my body?
It could be anywhere. Most of them start in the lymph nodes first, majority of them. And usually, if left untreated, the disease starts going outside of the lymph nodes over time. And it can go to the bone marrow, the liver, the kidney, any organ you might think of. There are a small fraction of DLBCL patients which present with a lesion in an organ without a lymph node involvement. Oftentimes their prognosis is still pretty good, but again, this is a very small fraction of patients. Majority is going to start with involvement in the lymph nodes, and that could be anywhere in the body because we have lymph nodes all over, starting from the back of the throat till the groin area. The majority of the big lymph nodes are. Spleen is also considered a lymphoid organ, so significant portion of the patients will have spleen enlargement as well.
How do I know the stage of my DLBCL?
It's a bit different than other types of cancers, such as lung cancer or breast cancer. We use something called Lugano staging system. So it basically is graded on involvement of different sites. So if a patient has only one area of lymph node involvement, that's stage 1. If they have multiple areas of lymph nodes involved, but they're just on one side of the diaphragm, let's say in the neck and the chest, or in the abdomen or the groin, it's considered stage 2. Stage 1 and 2 are considered early stage disease, and some of these patients might qualify for shortened treatment, 4 cycles instead of 6 cycles. If the disease is involving on both sides of the diaphragm, let's say there's a lymph node in the neck and there's a lymph node in the abdomen, this is considered stage 3. Stage 4 is when there is organ or bone marrow involvement. It could be kidneys, liver, it could be the brain or the lungs. People usually get very scared when they find out that they have stage 4 diffuse large B-cell lymphoma. But again, even at least 50 to 60% of stage 4 diffuse large lymphoma, and probably a higher percentage with the modernized treatment approaches, are going to be curable from their disease. So it's not the end of the road. It's, again, remains to be a very curable malignancy even in stage 4 patients.
What are my options for treating DLBCL?
They have multiple options. The most commonly used regimen is still something called R-CHOP. When they Google their disease, that's probably the first treatment they're going to see. There are now other FDA-approved treatments, something called Pola-R-CHP, or if they have certain alterations in the genetic makeup of their disease, they might benefit from something called dose-adjusted EPOCH-R. If they have central nervous system involvement, their frontline treatment needs to incorporate certain medications that goes into the brain. So there are very different approaches, and the treatment needs to be individualized. A majority of these treatments that are currently approved are chemotherapy-based. Pretty much all regimens with DLBCL involved targeted therapies as well. The most commonly used targeted therapy in DLBCL is anti-CD20 monoclonal antibodies. These are basically added to the chemotherapy backbone and given to the patients.
People all hear about this thing called R-CHOP. So each letter stands for a different drug. R stands for the rituximab, or the immunotherapy I was talking about. CHOP, C, H, and O stand for chemotherapy. And P stands for a drug called prednisone, which is a steroid. So R-CHOP is one of the still accepted standards of care to treat diffuse large B-cell lymphoma.
Of course, there's a multitude of other therapies, and we have therapies approved almost every 6 months for diffuse large B-cell lymphoma, and they include antibodies such as tafasitamab. It attacks specifically lymphoma cells and an epitope, so molecule on lymphoma cells called CD19. There is another amazing drug called polatuzumab, and then it's an antibody loaded with chemotherapy molecules. So it targets chemotherapy directly to lymphoma cells so that there is toxicity to lymphoma cells, but not the rest of the body. And there is this amazing new bioweapon called CAR T cells, chimeric antigen receptor T cells. So basically our own immune system cells, T cells, that are genetically modified in the lab to attack specifically lymphoma cells and do that very effectively.
Who is the best person to treat my DLBCL?
Usually they start with their primary care, especially if they're presenting with enlargement of the lymph nodes in the neck. Usually those patients are treated with antibiotics initially, thinking that this could be an infection. When they don't respond to antibiotics, usually they are referred to ENT specialists, and from there they come to us if their biopsies show lymphoma. Some of the patients are going to have different pains in their body, could be the bone pain or abdominal pain. They're going to start with certain scans. Maybe they're going to go to the ER first with that abdominal pain, and the CT scan is going to show enlarged lymph nodes. Some of the patients, rarely they will have organ involvement, such as the nervous system involvement. They're going to have a more dramatic presentation, could be confusion, could be seizures, could be altered mental status, but majority of them are going to reach out to us through their primary care physicians.
Well, the first thing is once it's diagnosed, you should seek treatment with a specialist, as I like hematology oncologists, because they're the ones that will decide what is the best treatment for the patient. And in some institutions, you can also access this newer treatment that I mentioned in the context, in general, of a clinical trial.
What tests will I need to do for my DLBCL and how often?
So everyone needs to have something called PET-CT if possible before they start treatment. That is the best modality we have to determine the stage before starting the treatment. And staging could make changes in the treatment algorithm. So it's important to do all the staging workup completely prior to initiation of treatment. Some patients, if they are considered at a high risk of central nervous system involvement, they will require MRIs of their brain and spine and a lumbar puncture to see if there is any involvement of lymphoma in their cerebrospinal fluid.
One other question comes is, do I need a bone marrow biopsy when I get diagnosed with DLBCL? The answer is not for everybody. Again, this is not a leukemia where, many major treatment decisions are based on a bone marrow biopsy. But if you suspect the bone marrow is involved, or the patient's blood counts are low for some reason, or you worry that they could have some other problem going on in the bone marrow, then you potentially get a bone marrow biopsy at diagnosis.
Once they start treatment, we do an interim PET scan and then an end of treatment PET scan. The treatment for DLBCL is usually 4 to 6 cycles of chemotherapy. Different practices have different timing preferences for the interim PET scan. It could be after the second cycle, third cycle, or fourth cycle. Everyone should get a PET scan done at the end of treatment, whether it is 4 cycles or 6 cycles, to assess their final response to treatment.
And once they're done with treatment, then the question comes, do I need to keep getting scans every month or every week? It's usually we don't really have to scan people. The guidelines, again, which are suggestions, recommend, at least for high-risk patients, we could consider CT imaging maybe every 6 months for the first 2 years. And thereafter, patients, basically, as I said, most of them are survivors. And then, it's about maintaining healthy lifestyle, then, watching cardiovascular health, diabetes, other side effects of chemotherapy, risk of second cancers. Those are the things that, kind of built into the aspects of survivorship, what happens after 2 years.
What treatment options are available for relapsed refractory DLBCL?
Again, with DLBCL, the chances of lymphoma coming back are about 40% or so. Of course, it's very individual depending on some initial risk factors such as age, such as stage, such as subtype. But we all always calculate the relapse risk individually for each patient. But if it does come back, we have a lot of tools. So as I have mentioned, there are a lot of novel therapies that are not very damaging for the patient's body in general, but attack lymphoma cells specifically. We have transplants such as autologous transplants, so the transplant for our own stem cells to consolidate the remission and make sure lymphoma doesn't come back. And then again, we have those CAR T cells, chimeric antigen receptor T cells, that work in lymphomas where nothing else is working. So basically, they're FDA approved for what's called refractory lymphomas. So no chemotherapy or targeted agents are working on this disease, and the CAR T cells can attack this disease and lead to substantial cure rates in these patients.
What is some of the most promising research being done to treat DLBCL in 2024?
There have been multiple breakthroughs over the last few years, and we are seeing different implications of that research that has been done over the last few years. The major component is immunotherapy, treatments using patients' own immune cells to kill cancer cells. There are a group of therapies called CAR T cell therapies. There are a group of therapies called bispecific antibodies. These are approved for relapsed refractory patients starting from the second line, but current research is incorporating these treatments to the frontline setting for patients that were never treated before, and that is very exciting, and that could improve the 60 to 70% cure rate over the next few years if these treatment modalities work better in untreated patients. There continues to be a multiple different approaches to increasing the options for different targeted therapies depending on targeting specific mutations or pathways in the tumor cell. All of these are very exciting, and again, I think they're going to make the cure rates higher over the next few years.
Thanks for watching. Visit healthtree.org to learn how you can become a Cure contributor.